So BP fluctuations in dialysis unit is a very important topic. You can encounter either hypotension or hypertension, and both have impact on morbidity and mortality for dialysis patients. So start with what is blood pressure. So blood pressure basically is a pressure, lateral pressure applied by blood on the walls of the arteries. So what do we have in blood pressure? We have got systolic blood pressure and diastolic blood pressure. So as we normally write, for example, normal blood pressure as 120 by 80. So the 120, which is on the top, depicts systolic blood pressure. So it's the pressure exerted when blood is ejected into the arteries. The normal systolic pressure is around 120 millimeters of mercury. On the other side, when the heart relaxes, the pressure that exerts within the arteries between the heartbeats is the diastolic blood pressure, here which is around 80 millimeters of mercury. Also, we need to know the concept of mean arterial pressure. Why am I mentioning about systolic blood pressure, diastolic blood pressure, and mean arterial pressure is because we are going to discuss about this in the forthcoming talks. So if you look at mean arterial pressure, it is an average arterial pressure during a cardiac cycle. So mainly it is considered that pressure which helps in perfusion of organs. So your heart, your lungs, your brain, liver, everything is perfused at the mean arterial pressure. And if it is above 60 millimeters of mercury, it sustains organ perfusion. If it falls below 60, then your organs are inadequately perfused and you can have ischemic injury to the important organs like brain, liver, causing further morbidity and mortality. And how do you calculate this mean arterial pressure? You multiply 2 times the diastolic blood pressure and add systolic blood pressure and divide it by 3. For example, if your screen shows a blood pressure of 106 by 70 millimeters of mercury, as per the formula, you are multiplying 2 into diastolic, your diastolic is 70, so 2 into 70, systolic is 106. You add both, the sum is 246, you divide it by 3, it is around 82 millimeters of mercury. And as we mentioned, if it is above 60, your organs are perfused nicely and you're in good health. And how do you measure blood pressure in your units? You have to make sure that the patient has rested well before you take the blood pressure. So a walking patient, a running patient, somebody who's come late to the unit should not be directly put to measure blood pressure. So you can ask him to rest for 5 to 10 minutes. The BP machine should be placed at the level of the heart. Your cuff size should be adequate to the arm size. The patient should never be sitting cross legs. While you are sitting cross legs, the BP will be shown 5 millimeters above the reading. There should be no stimulants you have taken before measuring the blood pressure, like coffee or any other stimulants. Averagely, 2 blood readings should be taken to confirm the blood pressure. And always, in our patients, after finishing dialysis, it's important to take both sitting and standing blood pressure. Because many a times you must have heard that the patient went a bit towards the lift and collapsed over there, and you found that the blood pressure was low. So if you take a sitting blood pressure and make the patient stand and take a standing blood pressure, and you find that there is a drop of more than 20 millimeters, then you're dealing with something called as postural hypotension, and the chances of patient to fall on standing is very high. So this part also is very important to record both sitting and standing blood pressure. The International Society of Hypertension has given a threshold for us to consider as approximately normal. So when you come to a hospital, your BP should be approximately 140/90 and below. Home blood pressure is considered as 135 by 85 millimeters of mercury. When in patients, somebody who comes to the hospital and the BP goes up, that is because of white coat hypertension or because of they are nervous about meeting the doctor. In such patients, we record what is called as a 24-hour ambulatory blood pressure monitoring. You have to get well versed with this word ABPM, 24-hour ambulatory blood pressure monitoring. So a gadget is connected to your hand and you're sent back home, which records 24 hours blood pressure. So you get an average of the whole day. So your 24 hours average should be around 130 by 80 millimeters of mercury. And most importantly, your nighttime average when you're sleeping should be below 120 by 70 millimeters of mercury. So with these readings, we come to today's topic, that is blood pressure fluctuations in dialysis patient, of which I would be talking about intradialytic hypotension, intradialytic hypertension. In between, we would be discussing a couple of cases, and also we will touch upon interdialytic hypertension, that is between the dialysis sessions. So starting the first part, intradialytic hypotension. Intradialytic hypotension is defined by KDOQI, that is Kidney Disease Outcome Quality Initiative. They have defined it as a decrease in systolic blood pressure of more than 20 millimeters of mercury, or a mean arterial pressure that we discussed before of more than 10 millimeters of mercury. Along with, you have symptoms of hypotension, that is, you got abdominal discomfort, you got some sort of sighing, some nauseatic feeling, vomiting, muscle cramps, restlessness, dizziness, or fainting, or at times anxiety. So if these symptoms are accompanying a decline in blood pressure of more than 20 millimeters of systolic blood pressure, that defines intradialytic hypotension. There are many two types of it. One is when during a session, you suddenly see a sudden drop of blood pressure, which we also call episodic precipitous drop of blood pressure during treatment. Or some people who have got advanced heart failure, severe vascular disease, chronic liver disease, malnutrition, they chronically, when they come for dialysis, they have hypotension, or what we call chronic hypotensive cases. So with this idea of what intradialytic hypertension is, we go to the risk factors which are involved, which patients are at risk. How can we identify those dialysis patients which can have intradialytic hypotension? So first in the category are the elderly people, those people who have been on dialysis for a long period of time, a longer dialysis vintage, patients who are diabetic, because you know that the arterial vessels can be thickened, they can have autonomic dysfunction. So both hypertension and hypotension are possible. Low pre-dialysis blood pressure. So they're coming to the dialysis unit with a blood pressure of only say 110/60 or 115/75, low blood pressure. People who have got low albumin levels, so their albumin, which is maintaining the oncotic pressure of blood, is on the lower side. So they have chances that they can have hypertension easy, as it becomes a confounding factor. Female sex, Hispanicity, and either higher body mass index. So obese people are also at risk of getting intradialytic hypotension. When you look at the causes, why would this intradialytic hypotension happen in our dialysis units? So I've just classified them in different colors. So looking at the most common and the most important and the fast developing is the red color, of which first point is rapid or excessive ultrafiltration. So patient comes with a weight gain of 3.54 liters, and in the first few hours, you are trying to remove around 2 liters. There is a possibility that the blood pressure will fall at the end of 1.5 hours. So rapidly reducing your weight loss or rapidly taking out ultrafiltration is commonest cause. Say with that, you have a rapid reduction in plasma osmolarity. Sometimes some patients will have a dry weight about 63 kilos. Now this patient is coming for dialysis for a month and he is improved on his health. He is taking good food, you are giving good quality dialysis, and the patient's overall nutrition has improved and he is put on 1 kg of weight. Now his dry weight has gone up to 64. But if you are still dialysing at a dry weight of 63, then the patient after dialysis can have hypotension, because here you have incorrectly prescribed the dry weight. So dry weight correction is also very important cause of intradialytic hypotension. Next section is about the cardiac causes, of which I have labeled it as blue in color. So in cardiac causes, as we mentioned, patients with long-standing diabetes can have autonomic neuropathy. Many of the patients will have diminished cardiac reserve. Patients can have any sort of arrhythmias in the dialysis unit. Arrhythmias means irregular heart rates, irregular pumping causing decreased cardiac output, causing hypotension. You can have a pericardial tamponade. You can have a blood filling into the pericardium suddenly because of increased anticoagulation. You can have valvular disorders, which can progress into heart failures and cardiac causes for hypotension. Or you can have an acute coronary syndrome in the unit, causing myocardial infarct or a heart attack like symptoms, and the patient can have sudden hypotension. Other causes to continue, sometimes what happens is patient is coming to the dialysis unit and you have first time and you have not told them that they have not supposed to come taking the blood pressure medications. So they come with knowingly or unknowingly, they have administered anti-hypertensive medications. So when they come to the unit, they start the dialysis and within the first half hour, the BP crashes. Some people have the habit of having food during dialysis. Some people eat more during dialysis. And what happens? The blood circulation is diverted from the cardiac output to the gastrointestinal system for better digestion. At the same time, when there is a drop in blood pressure, the symptoms compound and you can have a postural drop. So ingestion of meal immediately or before or during dialysis is also one of the causes, very common causes of intradialytic hypotension. Other than this cardiac, volume related, and medication related, and meal related, we have got another set of causes which are equally important. They happen intermittently or commonly, some very rarely. So systemic infection is very common. You patients who are on perm catheter or temporary catheter, it's very likely that they can have infection. Patients who have got lung infection or any other source of infection also can get systemic infection, go into sepsis and drop in blood pressure. The other causes, which I said, like hemorrhage is common. Some people may be bleeding. Sometimes the needle is out and the blood is pushing out, or this disconnection, blood loss, or they have got an internal bleed secondary to anticoagulation can cause hypotension. The rarer ones, hemolysis, if there is an event of hemolysis, you're seeing a very dark colored tube and the patient is having sudden drop, this abrupt drop of blood pressure and he becomes pale, then that's another very important cause of intradialytic hypertension. Patients who can have dialysis reactions. So the patient is getting dialysis reaction type A or B, the patient can have sudden hypotension, anaphylactic reactions, or otherwise because of the inflammatory mediators induced hypotension. And lastly, air embolism, another one common rare cause, but it should be kept in mind, which can drop the blood pressure instantly. Only one thing I would wish to highlight that whenever you talk about hypertension, the first thing is that you try to reverse the fluid and blood back to the patient. In specifically in these cases of hemolysis, air embolism are the ones where you are not supposed to get the thing back into the patient, whereas to cut off the dialysis and separately add saline to the patient. So these are one of common causes of patients which in dialysis unit which undergo and get into intradialytic hypotension. So now let's go to what are the symptoms. Many a time patients will have initially they will be asymptomatic and slowly they will complain of some sort of lightheadedness. People will feel that something inside I'm feeling very light. Some people may have cramps. Some people may have nausea, vomiting. Usually episodes of vomiting are common. Some people even can present with breathlessness. But more importantly, what I have always noticed, if you keenly observed senior dialysis technicians usually tell us that when he sees a certain patient who is yawning, sighing, or when he speaks, there is a change in voice. These are the very early markers of possible hypotension. When you are seeing these signs, you are taking the blood pressure, you will see it as around 130, but you may be surprised that within a few minutes down the line to half an hour, he may land up with hypotension unless there is any other secondary causes. So these subtle signs should be observed closely. Before going to the management or how to go about this after identifying risk patient, we have identified the causes, we know the symptoms. Now the patient is in front of us. Before going into the management, I would wish that you know few concepts before we treat the patient. So concept number one is about dry weight, which is very important. So when you look at this graph, which is in front of you, the day zero is the day when you have dialyzed the patient. Now the patient will come, this is 3 per week dialysis patient, so he will come after 2 days. So on day two, when he comes to the unit, this much volume overload he has got. So now you are dialysing at second point, patient post dialysis, the volume has decreased. Again, over the next day 4, he's again gained his volume. But this time the volume is on the lower side because each time the patient comes, you will be reinforcing the patient that he has to control his intake on fluids, water and fluid-like substances in form of curry, any sort of milk, chai, fruit juices, and etc. Now what happens is on day 4, he is again post-dialysis, he is almost reduced his weight to below the previous one. And after the third dialysis on day 6, he's almost reached closer to what is called as his dry weight. So what is dry weight? Dry weight is that weight when the patient is reaching his optimal fluid volume status, closer to his fluid volume status, optimal fluid volume status, along with no signs and symptoms of hypotension. So patient is not complaining to you tiredness. He says that when I go home, I'm feeling fine. I'm able to work. I'm not feeling giddy while walking, or even just after finishing dialysis, he's not feeling nauseatic, vomiting. So all these symptoms of hypertension is absent. The weight at which he is not having any edema, he's reached his euvolemic state, is called as the dry weight. And I would like to reinforce that we should assess the dry weight every week for this patient each time he comes to the unit, because as time passes, patient improves, his nutrition can improve, his dry weight can go up, or at the same time, if he is not doing well, his dry weight can go down as well. So this is point 1. Point 2 is how to assess very simply measures fluid overload and dry weight. So when you look at the clinical aspects, they are very cheap, simple, available, but they are not very sensitive. But you can look at the points. Blood pressure pre and post dialysis will tell you whether the patient has very high blood pressure. You can consider that there is a chance that he is in hypervolemia. Patient can have edema. Patient can have swelling in the abdomen called as ascites. When you examine the chest, you can see for presence of pleural effusion, pericardial effusion, or auscultation. When you look at the neck veins, you can see whether the neck veins are dilated. Is there a high jugular venous pressure? You can simply put the patient on the weighing scale and try to see the difference of weight. So these are some simple clinical measures to identify whether there is fluid overload. If you go to the non-clinical methods, which are more accurate using technology, radiology, lab reports, you can do an X-ray. It will easily show you if there is lung congestion. You can do an echocardiography. You can see whether what is the IVC, that is the inferior vena cava diameter, whether the IVC is the largest vein of the body coming out of the going into the heart for purification. So the IVC, if it is collapsed, you know that the volume is less. If the IVC is very full, you know that it is hypervolemia in the patient. And if the IVC is adequately filled, you know that he's in euvolemic status. You can use technology as bioimpedance, or you can use help of blood markers like ANP, blood volume monitoring, and hemodialysis as a concept we can continue. So these are some of the ways where you can assess whether the patient is in fluid overload, as well as slowly, gradually come to a fixed dry weight for the patient. Concept number 3 is how to increase blood pressure when there is hypotension in the units. What are the other measures? So one concept is of giving noradrenaline, that is the use of inotropic support. So if you have tried all the basic measures and your blood pressure is still on the lower side, you can use inotropic support like noradrenaline, which is coming in a strength of single strength or double strength. Single strength is 1 ampule is 4 milligrams. You are adding it in 50 ml normal saline and you are putting it as an infusion. Start at 2 or 4 ml slowly and then titrate your dose according to the blood pressure to keep the systolic blood pressure around 120 and maintain the blood pressure during this time. If the patient is chronic hypotensive, you may
Vilesh, you're on mute.
Okay. Is it clear now?
Yes, sir.
I'm not able to move my slides now. Okay. So double strength is 8 mg, which you can put in 50 ml normal saline, and you can titrate it to 2 ml per hour. And then again, according to blood pressure, you can bring the necessary changes. And usually when you start noradrenaline, you can start tapering from the 3rd hour and slowly taper out towards the end of dialysis. And during the use of noradrenaline, it is necessary to continuously monitor the blood pressure with a BP monitor, electronic monitor. Now, also there are presence of certain tablets called as midodrine. It's an inotrope diet tablet. We can take one tab 2 hours before the dialysis. Some people give 1 hour before the dialysis. This also in chronic hypertensive patients, it is used and it can be given in BD dose as well. It helps in maintaining the blood pressure during dialysis. Only thing to remember is a couple of side effects, that is supine hypertension and paresthesia and pruritus. Certain times we give the medication and we forget that this medicine can cause pruritus, and we tend to use or think about other measures, reasons for pruritus, and eventually end up finding out that this drug was the cause. And also you can increase the oncocity of the blood by using albumin or amino acids during dialysis to improvise the blood pressure. Now, the concept number 4 is about sodium remodeling. We all know that there is a function in the hemodialysis machine where you can titrate your baseline sodium, what you need to do. If you see this graph, I've just made a sodium profile versus ultrafiltration profile graph. We will only focus on the top column, which is the sodium profiling graph. You get these sort of 4 graphs in your sodium in your machine. The first one is a flat line where it's a control, which is like normal dialysis going on without any change. You have kept at a baseline of 138. In cases of intradialytic hypotension, you can consider the second one, which is a positive support sodium remodeling type, where you try to bring it the average around 143. You can set it up high at around 148 and slowly taper at 145, 140, and baseline 138. As the hours pass by, the machine will do it by itself. It will help you to initially have the blood pressure and get a good ultrafiltration going on during this time. Or you can have a no support or a normal support where your baseline is averaging around 138. The third graph where you can see that it is slowly going wider and wider and maintaining an average of around 138, or a particular non-alternating type of a sodium reprofiling where you can see that initially you start with 145, you bring down, take up, bring down. Usually in patients who have got a lot of fluctuations in blood pressure with autonomic neuropathy, where you can have hyper as well as hypotension. So with these 4 concepts in mind about dry weight, how to increase blood pressure using noradrenaline drugs, about the assessment of dry weight and the sodium remodeling, we will now see how we proceed in a case of intradialytic hypotension. So, okay, one more slide about intradialytic sodium profiling is that when you keep high sodium profiling, you should remember that advantages are that it decreases the risk of hypotension, it decreases the risk of intradialytic cramps, it decreases the risk of dialysis disequilibrium syndrome, but also it comes at a cost of, there is a chance of increase in hypertension, intradialytic weight gain can go up. So you need to keep titrating as the need comes, only then to sodium profile according to the categories provided to us in the machine, as and when the need comes as per the situation of the patient. So it is patient individualistic approach. So now coming to the treatment of intradialytic hypotension, you got first step is you stop the ultrafiltration. First thing, when you see that a patient has suddenly gone collapsed and you know that the BPS dropped, you put off the ultrafiltration. You have to place the patient in Trendeberg's position. So you take the patient to head low, you raise the leg, you keep the head low so that the blood circulation is coming towards the heart and it will be able to generate some blood pressure. You administer oxygen in patients so that you improve the cardiac activity. You give in a bolus of 100 to 200 ml of fluid, IV fluid saline, so that you can bring up the blood pressure, and then start evaluating what are the causes of hypotension and that particular scenario. So stopping ultrafiltration, positioning of the patient, administration of oxygen, and then pushing in some fluid to initially try to sort of get into the situation and try to cut off the drop in blood pressure, and then only to evaluate the cause of hypertension. If you have multiple people around you, each of them can distribute the task so that the time required will be less. In assessment, you need to reassess or increase or decrease the dry weight, to adjust to the needs. As I mentioned, the case number 1 who came to the hospital with 63 kilos of dry weight, and later on he, with a good dialysis at your unit, improved to 65 kilos. but we continue to dialyze the patient at dry weight 63, repeatedly going into hypotension. And in such cases, we need to increase the dry weight and try to settle the hypotension and get the patient become better. You have to ask the patient to avoid taking food if he is taking food during dialysis. You need to modify the timing of anti-hypertensive medications. You have to tell the patient that he should not take the blood pressure medication before coming to the unit. And also during the dialysis session, some people unknowingly they can take some medications. You can ask the patient to limit the sodium intake, or what we call the salt intake. The more the salt intake, more the water retention, more the hypervolemia, more the chances that your weight gain will be high. And when you come here, you try to remove the weight gain and the patient can go into hypotension. You have to make sure that your dialysate magnesium and your calcium are all adequate. You have to reassess what dialysate sodium prescription you have kept for the patient. You have to assess what is the sodium of the patient, whether the sodium of the patient is on the lower side, whether we need to put it on the higher on the sodium profiling panel. So these are the basic assessment and basic steps to be taken. Next step will be, once you have gone through this your chart, flow chart, and you identified that there is no other cause, the patient has not taken food, there is no antihypertensive medication given, your dry weight is correct, everything is okay, then start evaluating the next thing. You think about whether there is cardiac function. How is the cardiac function? You can go for evaluation of cardiac function. You can use a pool temperature dialysate, which can cause vasoconstriction and rise in blood pressure. You can increase the dialysis time. So sometimes it happens that you're trying to remove 4.5 liters in 4 hours. You can discuss with the patient and the relative the need to increase half an hour or 1 hour to titrate that dialysis, or reschedule his dialysis the second day itself back to back and try to remove the excess weight gain so that it is easier and there is no episode of hypotension during that treatment. As mentioned before, you can take help of tablets like midodrine if there is a chronic hypertensive, his blood pressure is dropping at each unit. In spite of assessment, you have to give them 1 or 2 hours before. Dose is around 2.5 to 5 mg. You can use noradrenaline during the course of dialysis, or you can add IV albumin. It's very costly, but depending the patient's status and if he is along with, he's got a CLD, if it is going to help him and it is a affordable patient, you can give the option of IV albumin, or you can just also limit yourself to IV amino acids, which also will help you in a little way to pump up the blood pressure along with other measures. So also after doing all this, there are certain things which we don't look into. So one of the most important thing is correction of anemia. If the patient's hemoglobin is on the lower side, say 8.0, 7.6, 5.4, so we need to correct anemia according to the hemoglobin level, either by erythropoietin, iron, or blood transfusion. And get the blood, as the blood hemoglobin improves, it indirectly improves the cardiac function, it indirectly improves the blood pressure. You have got heart failure patients. Some patients do have heart-related heart failure symptoms who are always chronic hypertensives. Nowadays, you can give drugs like digoxin, or later newly come drugs like losartan plus sacubitril. Azmada is just a trade name. I just want to highlight that name because people are well versed with these names. So these are drugs for this. Sometimes it has happened in our units that because of not understanding the name and content of the drug, we have stopped the drug thinking that it is just for A and Z is multivitamin A to Z, and that happened to lead that patient into repeated hypotensive episodes later on. So we need to, whenever we cut off a drug from a chart, you are important to note whether this drug is used for any such purpose of importance to maintain blood pressure during dialysis or otherwise. So with all this background knowledge about risk factors, causes, treatment, concepts, and how to go about it, I would like to bring your attention to some cases which we normally see in our units. So let's start with the case number one, a 59-year-old male who is a known case of chronic kidney disease secondary to IgA nephropathy. On hemodialysis, he was doing it 3 times per week. Now he has come to the dialysis unit with a bilateral edema feet. He's got crepitations in the chest. When I talk about bilateral basal crepes, I in my unit make sure that every technician should auscultate the chest of a patient, because you should learn to hear that the signs and the symptoms and auscultatory findings of the fluid in the lungs. It is very helpful for everybody. So as soon the patient comes to your unit, first thing you assess the fistula, you put a stethoscope and just put a stethoscope on the back of the chest and see whether there is presence of crepitation. Why I'm saying this is an upgradation of our own knowledge, and it also helps the patient till the doctor comes. You will be able to titrate the ultrafiltration. You know what is the problem at your level. So clinically, if you have got edema in the legs, you have got crepitations. So in this case, it is present. So during a third hour of the dialysis, he complained of lightheadedness and he vomited twice. So there was some symptoms of emptiness to him and he vomited. Now, following which he fell unresponsive. The blood pressure at that point of time was around 70 systolic. And most importantly, the sister found that there is some feeble pulse, and that pulse is very irregular in nature. So looking back at this case, look at the highlighted points. You have got a patient who has got edema feet and bilateral crepes, which indicates that the patient is in fluid overload. Same time, you have got symptoms of lightheadedness and vomiting with a systolic BP of 70. That shows that the patient has got hypotension and the symptoms related to that. And now, also one information along with that was that there is a irregular heartbeat. So it seems like this patient has got some sort of rhythm abnormality, arrhythmia. So the immediate measures, what will we take in such a situation? First thing, as we mentioned, we should quickly put the patient in head low position. You are stopping the ultrafiltration. You are returning the blood if it is possible. No CPR was required at this point as the patient had heartbeat. Most of the times, there are certain patients who have telltale signs of chest pain secondary to CPR given when the blood, there was heart rate, there was blood pressure. So please make sure that unless there is a real need of a cardiac arrest situation, we may not need to give CPR at the onset. Second thing, after that, the patient was given 200 ml of bolus saline. Most of the units practice to give 100 ml 25% dextrose along with it so that we don't waste time to find out whether it is hypoglycemia, hypotension, and also that when you give dextrose, you're infusing another 100 ml into the patient, so it will help in bringing up the blood pressure. So loss of time and good effects. So here it was done. They were given 100 ml dextrose and 200 ml of saline was pushed. They were given some pantoprazole, some granisetron, that is MCED 4 mg for the vomiting. And now the patient was getting a little better. So they thought because of the irregular rhythm, they took an ECG. Now, as you friends can see on the screen, the ECG, you've got a P wave, there is a QRS complex, there is a T wave, there is a gap, then again a P, QRS, P, QRS, there's a long gap, then again a QRS complex. So there is a irregularity between the RR complex as you see in this ECG. So this is definitely an arrhythmia. So which arrhythmia? So coming to the next slide, as you see there, a normal heartbeat would have given a regular R complex with equal distancing because the node generated impulse is a SA node and it is going to both sides of the ventricles, pumping in a regular fashion. Here you got multiple abnormal impulses and that is why it is beating irregularly. And here you can see that the patient is in what is called as the diagnosis is atrial fibrillation. So heart is beating at its own different rate, because of which the cardiac output has decreased, the patient has gone into hypotension. So an antiarrhythmic drug, Cardrone, was given as an identification of the atrial fibrillation. Cardiac consultation was done to determine the cause and patient's dialysis was stopped and patient was shifted to the ICU. Now coming to case number 2, here you have a 54-year-old female who is a known case of chronic kidney disease on maintenance dialysis 3 per week, has come with a weight gain of 5 kilos. So you are here you can find out the weight gain is 5 kilos. Patient's breathless. He's got a saturation of only 70%. That the BP at the beginning of the dialysis is around 110-60 millimeters of mercury. So once again, looking at the highlights, here you've got a 5 kg weight gain. Oxygen is already low, so you need an urgent ultrafiltration. But the dialysis at the beginning is BP at the beginning is only 110/60. So you've got a case of low blood pressure and a large weight gain, which you see very commonly in your units. So then how will we proceed here? So approach was to give oxygen support first as saturation was less. You try to, here we need to act fast. We want to remove ultrafiltration. So we didn't wait for other, you have to put the patient in a little head low side position, but importantly, you have to start noradrenaline support to increase the blood pressure so that we can start the UF slowly. Once the blood pressure is obtained, we can do an isolated ultrafiltration so that we can remove some fluid faster and get the patient not going into oxygen D or hypoxia or ventilation, and can get better with only oxygen support. One more point which I mentioned before, we don't have to remove all the 5 kilos in one setting in this patient. We can remove around 3.54 to make the patient better, and you can go for second dialysis the second day. So do HD next day to remove the extra weight. All in one go removal of fluid will cause hypotension for sure. At this point, we could give some amino acid solution to maintain the blood pressure. You can also give albumin, and midodrine 1 tablet 1 hour before dialysis was considered for this lady because she was coming chronically in a hypotensive state. So these are implications of the concepts which we learned before and how we manage a patient in such a situation. So ending with intradialytic hypotension, we go to the second part of the talk. That is, one side the blood pressure was low. As you see in this picture, the blood pressure here is very, very high. So how to go about with intradialytic hypertension? So when you look at intradialytic hypertension, there are many definitions outlined, of which very important ones are, if there is an increase in your mean arterial pressure of more than 15 millimeters just during or immediately after hemodialysis, if there is an increase in the systolic blood pressure of more than 10 millimeters of mercury from the pre or to post dialysis, so from the start to the end, you have lost more than 10 or 20 millimeters of mercury, or you have got a during the hemodialysis because of significant ultrafiltration, still you are having a hypertension at the end of second and third hour. You have got an increase in blood pressure which is resistant to ultrafiltration. In spite of ultrafiltration, BP is just going up 160, 180, 210, or you have got aggregation of or existing hypertension is becoming aggravated, or because of any other agents like erythropoietic stimulating agents. So with this sort of a background of rise in blood pressure during dialysis, we come to what are the causes of the same. So as you see, the most important cause of any intradialytic hypertension, about 60 to 70% of the cases is volume expansion. So because of lack of proper correct fluid intake, we come with fluid overload. There's always that the dialysis sessions are to be done 3 times, 4 times a week, but patient are irregular in their dialysis sessions. They accumulate fluid in the body, and that eventually leads to hypertension. Sympathetic overactivity from the kidneys, the activated renin-angiotensin system when there's increased ultrafiltration, hypovolemia status. You've got a difference in the intradialytic sodium-calcium variations, or you've got increased cardiac output states. Chemically in the body, if there is increased endothelium release from the vessels, you get vasoconstriction and cause hypertension. In diabetic patients and otherwise, where there is hypercholesterolemia, you get into arteriosclerosis and it is narrowed arterial vessels causing hypertension, or your anti-hypertensive medications which you are administrating are being removed during hemodialysis by dialysis membranes. So in this very important point in most of the patients, what we find is that one is volume expansion. Some people have very high salt intake during their diet, and that causes rise in blood pressure, which needs to be discussed with the patient, and all the remaining causes, including the most important about hypertensive medications. So I put a slide on anti-hypertensive medications to know which are the medicines which are removed by dialysis and which are not removed by dialysis. So when you look at the chart, you've got ARB, that is angiotensin receptor blockers, like you must have heard this name, telmisartan, losartan. These are the drugs which are not dialysable. You've got calcium channel blockers like amlodipine. You've got beta blockers, specifically like carvedilol, which is one of the drugs which is used in hypertension in dialysis units in intradialytic hypertension. Propranolol, esmolol. The other drug now by which you are commonly familiar with is arcamine, the content of which is clonidine, hydralazine, and prazosin. These are are the drugs which are not removed by dialysis. I'll again put it to you. It is telmisartan, amlodipine, carvedilol, clonidine, hydralazine, and prazosin. I always remember this for short. This thing I remember that whenever the blood pressure goes up, I have to remember the drug name as CAT, carvedilol, amlodipine, and telmisartan. So whenever somebody calls and tells me that there is a blood pressure rise during dialysis, I quickly think about these three drugs: carvedilol, amlodipine, telmisartan. That is CAT, which is not removed by dialysis. And drugs which are easily removed by dialysis are ACE inhibitors like captopril, enalapril, beta blockers like atenolol, metoprolol. When the BP in a normal setting at home shoots very high, more than 160, 190, 200, we call upon the patient to take tablets called minoxidil. And this minoxidil during dialysis, if it is given, is not effective. Sodium nitroprusside, which we give in place of NTG, nitroglycerin in some cases of high blood pressure, is also dialysable, which we need to know. So after coming out of this important topic of antihypertensive medications, another important point is how will you know that these patients are having blood pressure issues? Is by BP monitoring. We cannot arrange an ambulatory blood pressure monitoring for all patients. We have to ask them to do what we call as home blood pressure monitoring, which is most important. They need to take 2 readings per day in between the week, and you have to treat these patients with additional anti-hypertensive medications if the BP is more than 140 by 80. So we need to know from them whether they are having high blood pressure during the day in their home as well as in the unit. If home blood pressure monitoring is not present, then we take a median intradialytic blood pressure of 140/80 as an average blood pressure for the patients who are having consistently high blood pressure even during dialysis. For example, in a patient who is dialyzing Monday, Wednesday, Friday, if the systolic blood pressure is 146 millimeters of mercury on Wednesday, that is a midweek, that means that a patient is very likely to be hypertensive and will come to you in the unit with a rising blood pressure in the course of dialysis. So what will we do for these patients who are having intradialytic hypertension? First thing is to assess your volume status, which I always said that it is very commonly, as Dr. Georgie Kenan sir always used to point out, that whenever you see a patient of hypertension in your dialysis unit, slowly and gradually, not very quickly, you should titrate the dry weight around 0.5 to 1 kg per week and slowly try to bring it down. And the blood pressure, slowly you will observe that it keeps coming down over a period of 2 to 4 weeks. And at this point of time, when the blood pressure is coming to the dry weight, you may also notice that you are reducing the number of anti-hypertensive medications on the other side. It should not happen that the patient takes the same amount of anti-hypertensive medication as you decrease the dry weight, so that he then comes to you with hypotension. So along with dry weight adjustment, blood pressure medication adjustment is also important. Reduce dry weight slowly. That is the main message which I want to give in this slide. Sodium profiling can be done for this same as well. You can decrease the sodium and titrate it upwards down in the profile. Antihypertensive medications like beta blockers, carvedilol, atenolol, calcium channel blockers, cilindipine can be considered. But addition, certain times we find that because of the oversympathetic renin-angiotensin system working along with it, even losartan and telmisartan in potassium patients with less potassium, less than 5, can be considered as a part of hypertensive management during or even after dialysis sessions. And minoxidil is one good drug, which you remember by these names, which are common. That's why I put it in the bracket, which is the content of these is minoxidil, and that will also help in good blood pressure control in the interdialytic era. So we have looked into all the aspects of intradialytic hypertension, but when we do all this, we keep forgetting the general measures, which are the most important thing which a dialysis technician can directly convey to the patient. So each time the patient comes, you will keep telling that diet has to be counseled. You have to tell them about water restriction, which needs to be reinforced. When I tell you about water restriction, even I had a myth in my mind that how much ever you tell the patient is not going to listen. This was my concept as well when I used to deal with these patients. I try my best, but sometimes some patients don't listen. But then there are studies to show you that if you continue to keep telling the patient or reinforcing the patient, at the end of 3 months, they noticed that the total weight gain was reduced by plus or minus 1.5 kilos. So thereafter, every patient, in spite of not listening, if you keep on telling him, discussing with him, there is a rapport which is created, and that explains to them that there is a need. And when they come in at certain difficulties like breathlessness, they themselves learn to modify the water intake. So water restriction to be reinforced is one of the most important measures. Walking 30 minutes, you can always tell a capable self-independent dialysis patient that he should walk 30 minutes per day. And to those dependent patients who are very feeble or weak, they can, with support, just move in the house. That movement could enough be helpful in helping us in controlling blood pressure. Mild exercises like just moving the hands, swinging the legs, sitting exercises can be done by these patients. Yoga is the best technique, and in diabetic patients, a good diabetic control is very important. Just passing by, as I finish the both important topic, I'll just touch upon one aspect, that is interdialectic hypertension. That is the rise in blood pressure in between dialysis session, more than 140/90. In between the dialysis sessions, in terms the patient is on Monday, Wednesday, and Friday, but he has, as he goes home, he finds that his blood pressure starts creeping up in the end of the night, and by next day afternoon, he's having a BP of more than 160/190. This is again secondary to hypervolemia as a primary reason and sympathetic overactivities. Addition of beta blockers and calcium channel blockers discussed before helps in decreasing the blood pressure, along with the standard nifedipine retard and other drugs like clonidine. Home BP monitoring is the only method by which you can easily diagnose intradialytic hypertension, as well titrate the drugs in such a way that it does not cause intradialytic hypotension or hypertension. So my take-home messages for the day is that volume status is key to BP variation in SD unit. Dry weight assessment at regular intervals helps in decreasing mortality, because there is a direct impact of intradialytic hypotension each time all the important organs are getting ischemic, and their work progression is decreased, and you're causing increased morbidity and mortality. Head low position, bolus saline, noradrenaline, and midodrine like drugs, proper ultrafiltration and sodium profiling helps manage intradialytic hypotension. Non-dialysable anti-hypertensive medication, the word which we said, CAT, carvedilol, and your telmisartan, amlodipine should be remembered. And diet in terms of fluid intake and salt intake, keep regularly reinforcing them so that they don't get into these complications. Thank you.